Myasthenia gravis. So back in 1972, myasthenia gravis was actually described as a chronic disease characterized by fluctuating weaknesses which were aggravated by exertion and improved by rest. There are 6 subgroups of this disease. Importantly, we look at the thymus and how it's affected by each subgroup. So in the early onset group, which is below 50 years of age, we see hyperplasia, which is this increase in the amount of organic tissue of the thymus. Contrastingly, over 50 years of old, we see the atrophy of the thymus, which is that muscular or that decrease in size and mass. Like anything with age, we atrophize. So that's a given, it's a trend, and it makes sense. In our thymoma subgroup, the thymus actually experiences or can sometimes be impacted by lymphoepithelioma, which is a rare type of lung carcinoma. Multispecific kinase and lipoprotein receptor-related protein 4 actually don't affect the thymus at all. And in our seronegative and ocular subgroups, the thymus, there's variables there. So depending on the variables associated is dependent on how the thymus is affected. In this one here, we have an image comparing a healthy neuromuscular junction compared to an MG, myasthenia gravis neuromuscular junction. The biggest issue we see there is that reduced muscular contractionability. Pretty much what happens with myasthenia gravis is the antibodies that bind to the acetylcholine receptors at the neuromuscular joint encourage this weakness of skeletal muscle, which can also lead to weakness in the eyes. And we see these things such as diplopia and ptosis, which is our double vision and our droopy eyelid. Signs and symptoms of myasthenia gravis. So we have things like limb weakness, ptosis and diplopia, depression, anxiety, alopecia areata, which is a sudden and patchy loss of hair, fatigue, and dyspnea, which go hand in hand together and are thought to be due to anemia, which is that loss of iron. Myocarditis, which is inflammation of the myocardium. Dropping of the head. In my study, you'll see there was actually an article I briefly went over about a 61-year-old woman who persisted with dropping head and she was later diagnosed with MG. Effects on movement control. So again, we have that diplopia and the ptosis, the drooping of the eyelids and double vision. Neuromyotonia. So neuromyotonia is this hyperexcitability of the peripheral motor nerves. Pretty much means there's an intermittent and continuous muscular contractions happening, involuntary, and cramps. Myokymia is an involuntary eyelid muscle contraction. 60% of our symptoms are the common symptoms spread to other muscles, and this leads to things such as dysarthria, which is a motor speech disorder, dysphagia, which is difficulty in swallowing, chewing problems, and dyspnea, again, that shortness of breath. And now treatments and interventions. So in late onset MG, long-term immunosuppressive drugs are the cure. Doesn't always work. It depends, obviously, individual factors. Steroid medications, if this is an option, patients need to be monitored for their weight gain, their blood glucose if it increases, and hypertension. Pyridostigmine is a preferred drug for all subgroups. The dose is based on the effect it has on individual muscular strength, and the dose also depends on the size, depends on the side effects. For patients who have thymoma, we do a thymectomy, which is removal of the thymus. In severe cases, we have an intravenous immune globulin and plasma exchange. This comes down to individual factors. They could not be well enough, they're too old. Institutional experiences, is the institution experienced enough to do this? Availability, do they have doctors willing to do it? Do they have staff who are able to do it? Equipment, if it's traditional, it's not very traditional. Some hospitals might not want to do it, they don't believe in it. It's more convenient though, this intravenous immune globulin and plasma exchange, and it has less severe side effects, but that's obviously dependent on individual factors. Exercise, it's a given. Physical activity and exercise at low to moderate level can help increase, but just help with muscular contractions and strengthening. Although you can't get rid of it, it does help. Like anything, exercise is always a recommended intervention. Corticosteroids, they have been used, and rituximab, which is used in the muscle-specific kinase, myasthenia gravis, which can actually thought to have an increased chance of a favourable outcome.